Okay, so good evening everyone and welcome to the 24th session of the online Optom learning series. And today we have with us Professor Bruce, and welcome back Professor Bruce again. And we are very fortunate to have you back. And he is going to talk to us today about the more of practical and clinical examination aspect for younger children and children with special needs. So thank you again, Prof, and we are very eagerly waiting for your talk.
Okay, well, thank you very much. First, I'd like to just acknowledge funding that I've received for many years from the National Eye Institute, the National Institutes of Health. It's part of my big research study, the Vision of Preschoolers study, specifically the component of the phase called Hyperopia in preschool. I also want to mention that I get some consulting funding from Welsh Allen, the maker of the Spot autorefractor, photo screener, and also the ophthalmoscope and retinoscope that many of you had. I also want to acknowledge two recent talks as part of this series that I thought were really excellent. One was, and I hope I get the pronunciation of the names even remotely close, Sakina Musahi, who gave a talk a couple of weeks ago on pediatric eye examination. She's from Kenya. And Dr. Kashama Shah from India, who gave a talk the other day about visual development. And I would suggest to the audience, if you haven't seen those, please do so. And I'm going to refer a little bit back to both of those talks in my talk. So thank you for both of those excellent presentations. First thing I want to do is I want to show you couple of videos, and I want to say this is with thanks to my old and very good friend, Dr. Leah Hyväräinen. Dr. Hyväräinen is a Finnish pediatric ophthalmologist from Finland. She is, among many things, the developer, inventor of the Leah symbols visual acuity test. She gave these videos to me some time ago, and I think it sums up a whole lot of the reason for us wanting to do examinations of very young children and to try to understand what's going on. And the title of the slide is Things Are Not Always What They Seem at First. This child came to Dr. Hyväräinen at 4 or 5 months of age with a question of infantile autism. That was the tentative diagnosis. And they wanted her to do an examination and see if in fact there was anything going on. So watch these very closely. Now watch the reaction of the baby. Look at the aversion that this baby has to looking at her mom. Also notice the sibling, the brother. That mother is trying to get that child's attention, and that child will simply pay no attention and is turning away as much as possible. Again, notice the sibling. Okay. Now watch. Putting on a pair of glasses. These are about +5s or 6s. Look at the reaction. Now that baby is looking at the mom, is paying an inordinate amount of attention. I'm just going to run that one more time. Glasses go on, and look at the incredible difference in that child's behavior with simple hyperopic correction. Hyperopic correction alone in a 5-month-old totally changes that child's behavior. And if you notice, the sibling, the brother, also had, as I like to call it, big, thick, ugly glasses and has crossed eyes. Child is a high hyperope. The baby, the sibling, turns out also to be a high hyperope. This child does not have infantile autism. So that, to me, summarizes why it's important for us to be able to do examinations on young infants. Okay, so now let's zero in a little bit. The ideal exam process, as far as I'm concerned, integrates an understanding of three things: basic science, clinical science, and clinical practice. And the best examination process includes all three of those. If you watch a technician, an ophthalmologic technician, doing parts of an examination, in general, they know virtually nothing about the basic science. They know very little about the clinical science, but they do know how to do a procedure probably very well. As optometrists, it's important for all of us to be able to integrate all three of these things that are all part of our educational program. Now, in terms of the pediatric examination process, as I've said in my other talks, it is absolutely essential that objective testing is the essence of the examination process. We do exams on adults or older children. We can ask questions, we can get responses. With babies, we have to do the observation. Now, it's also critically important that we be very, very fast in what we do, and we're very flexible in how we approach the examination process. We can't be rigid. We can't follow a series of steps in an orderly manner. We have to adjust our examination to deal with the reality of that child. And as we're doing the exam, we have to be a continual observer of the parent and the child and their interaction. So each component of a typical examination in an adult is still necessary in a young child. And I'll go through that in just a minute, but all the pieces that we do with adults to determine what's going on as far as their visual status, we still need to do with a young child or a child with special needs. How we go about performing those various components of the examination is really what the issue is about, and really is what I'm going to be talking about today. And finally, what I want to say here is that the best examination flow occurs when the parent and the child don't even know that we're doing the examination. In other words, the mom and the child come in, they sit down in the exam room, we start doing things as we're talking, as we're developing a relationship with the parent and the child. We're already going through the examination process. We're not doing it one step, write down things on a piece of paper, do another step, write it down. It's a fast flow, and it has to be well integrated. Now, one of the really major constraints in doing examinations of very young children or special needs kids is that we're rarely able to get all the information that we normally depend on in the exam of the adult. There are many things that we can't do in the same way. We don't get a direct history from the patient. That history is filtered through the parent or whoever is with the child. So we're getting, in effect, secondhand information. Our ability as examiners, as optometrists, is imperfect to observe what's going on. And throughout the whole examination process, the level of compliance by the patient and what we're doing is limited. So if we, with an adult, ask the patient, look at the chart at the end of the room to relax accommodation, obviously we can't control the child's responses in many cases. There are things we can do to try to get that control, but still it's imperfect. So in essence, the exam process is objective versus subjective. Subjective may include our ability to observe, but it really is objective in essence. We've got to determine what the information is. We've got to integrate that information together. We don't have the luxury of being able to ask the same kinds of questions and do the same kind of testing process that we do with adults. Now, here's a little bit of a trick question. And if I was in front of you in a lecture hall, what I would do here would be to say, what are the two most important optometric tools? And I would point at people in the room and I would say, tell me what you think. And somebody would say, oh, it's the retinoscope, or it's the ophthalmoscope, or it's the this or the that, the visual acuity test. But actually, it's not those at all. Two most important optometric tools are your eyes and your brain. It's your ability to observe and your ability to communicate in both directions. So what we teach our students nowadays is, especially in the US, is a major dependence upon technology. We are completely enamored of the use of technology. We like fancy tests, we like procedures, but in fact, and this is true with adults, it's true with children, it's true with everybody. We have to observe what's going on, and we have to figure out what's going on. So it's really your eyes and your brain. And for students who become dependent upon technology, I would urge you all, develop the technique of observation. Develop the ability of thinking. That's the most important part. The technology helps us. Sometimes it helps us tremendously. But the essence of the examination process for an optometrist or an ophthalmologist or a general surgeon or anyone else involved in the healthcare is your ability to observe and your ability to think. All right, so what are the components of the pediatric exam? As I said, they're exactly the same as the components of the adult exam. You start off by observation, and for me, observation begins the instant I meet the patient and the parent. That instant, maybe it's in the waiting room, maybe it's in the exam room, but immediately I am beginning my examination process. Then, of course, there's a history, there's visual acuity testing, there's ocular motility and binocularity, there's refraction, and there's ocular health. Again, all the same components. However, the way we go about it is different. It needs to be modified significantly. All right, so what's observation? Well, what are we observing? Well, we're observing the visual behavior of the child. So as soon as you see the parent and the child, you start looking about how that child is dealing with the environment around them. Whether they're able to see things, whether they see the mom, whether they see motion, whether they pay any attention to the examiner. You're looking immediately at the ocular alignment and eye movements. Do you see nystagmus? Do you see some other funny kind of eye movement? Do you see strabismus? You're looking at the child's general behavior. You can make an assessment almost instantly about what is going on with that child. Is that child developmentally delayed? Well, you use your knowledge, as again was brought out in the discussion by Dr. Shah the other day. You use your knowledge of visual development and overall child development to understand if there is a significant delay. If you have a child that is not grasping for objects beyond a month or so of age, you immediately know there's something going on. The last two items are terms we use kind of facetiously. We're kind of kidding around among ourselves. We think about funny looking eyes and funny looking kids. Well, you could just look at a patient and you kind of get an amazing gestalt, an amazing understanding almost immediately about, is there something odd going on? If the child looks abnormal in some way, if the child has a craniofacial abnormality, the child has abnormal motor development, motor movements, you can see that instantly. So what are the most important things you want to know about a baby? Can the baby see? Can the baby function in the world around them? And again, this was all brought out in the discussion by Dr. Shah the other day. And again, I implore you, go look at her talk. It was great. In the history, you want to know, are there important morbidity and mortality issues within the family? If a family has a history of nystagmus, well, if you see nystagmus in this child, does that tell you anything? Of course it does. History, I'm going to skip over this. You've, again, the talk a couple of weeks ago, I think brought out a number of details in really a very nice way. There's lots and lots and lots of questions you can ask. There are a list of these things. I generally like to get a history beforehand, written if I can, but I like taking a history myself, and I'm doing that as I'm doing the examination. I don't do the history before I start doing tests. I'm doing tests at the same moment that I'm taking a history. I'm asking questions and I'm modifying those questions and the order of those questions, the depth of those questions, depending on what I'm seeing as I'm going along. And as I see things in my exam process, I'm asking additional questions that may be appropriate. So again, I'm going to skip over that a little bit. In the talk a couple of weeks ago, there was a discussion about the APGAR scores. I'm just going to mention this briefly. And you can see the letters A, P, G, A, and R on the left side of the screen. What the lecturer did not mention is that APGAR actually was not based upon those. It was based upon what's at the top of the screen. The person who developed the APGAR scoring system was a doctor named Shirley APGAR. She came up with this scoring system in the early 1950s. And it was rated typically at 1 and 5 minutes, and you can see the details on the screen. And again, it was presented a couple of weeks ago, but I just wanted to point out this was not the use of those letters to come up with the indicators. It actually was based upon the woman's name. So visual acuity. We know, and again, this was brought out in prior lectures, in an infant and a 1-year-old, well, obviously, you're not going to be doing recognition acuities. You're not going to be doing LEA or HOTV or tumbling E charts for all the obvious reasons of child development. Child does not have the cognitive ability to do these until about 3 years of age. Some more precocious kids can do it earlier than that. I've been able to get responses down to 2 years of age sometimes by using a matching test. I'll show you that in a minute. In the US, we typically use LEA or HOTV starting at around age 3, but again, I may try it earlier. We don't use tumbling E at all in the United States. And the reason why, I think was also brought out in the development talk the other day, and that is that the issue of laterality as a developmental component for children is still developing, even during the preschool years, 3 to 5 years of age. And in many kids, even later than that, 5, 6, 7 years of age. Kids can't do left and right as well as they can up and down. So when you're doing a horizontal positioning of a tumbling E, responses you get may be anomalous versus up and down, which tend to develop at an earlier stage. So in the US, we really don't use E's anymore. We use LEA and HOTV. All the research being done in the US on children over the last 25 or 30 years uses either one or the other. The simplest approach for a baby, and sometimes for a special needs older child that may not communicate well, think autism specifically, maybe fix and follow with a light or a toy. Now, when the parent makes an appointment, we always tell the parent, please bring in some of the child's favorite toys. So if a child has a favorite doll or a toy, we really want that to be brought in. And we want that because we know the child is going to pay a lot of attention to that, whereas they may pay much less attention to something new, a toy that I have, that I'm using as a fixation source. You can use a light, you can use a toy. There are lots written about the value of one versus the other. I'm not going to get into the particulars of that. But the simplest way that I assess visual acuity as I'm beginning the process is simply hold a favorite toy, begin doing a cover test, and I'll use the cover test, and I'll usually just use my thumb in front of a child's eye. I'm just trying to break up fixation. So I'll do a cover test as I'm moving that toy in different positions of gaze. And if the child objects to covering one eye versus the other eye, what does that tell me? It tells me that the vision on the eye that is being evaluated, in other words, the eye that's not under cover, is probably poorer than the other eye. And if the vision is poorer, in a sense, that's all I really need to know. The quantitative measure of visual acuity as an initial part of the examination on a young child, in my opinion, in a clinical examination, I'm not talking about a research exam, I'm not talking about an examination in a hospital setting. I'm talking about doing an examination in a clinical setting where the issue of time is great, where you have other patients waiting and you got to get through important aspects of the exam as quickly as possible. This is the way I do visual acuity testing. I want to see if there's a difference. If there is not a significant difference in vision between eyes, in other words, if there doesn't seem to be an aversion to covering one eye, then I can be fairly secure that there may be a small difference in vision, but there almost certainly is not a big difference in vision. If there is a big difference in vision, then I'm really interested. Then I want to know what's going on. If vision is really bad in both eyes, what am I likely to see in a child over the age of a few weeks of age? I'm likely to see nystagmus, or I'm likely to see poor visual function in terms of looking at objects, looking at the room around them, looking at the mother. If there's a normal sort of visual functioning going on with both eyes uncovered, but there is an abnormal tolerance to occlusion of one eye, that tells me that there's a problem with that one eye. Do I know what the problem is at this point? No. Could it be a refractive thing, an amblyopia thing? Well, it could, although not really likely on a very young child, because the only kind of amblyopia that happens in a 1-month-old, for example, is going to be deprivation from a cataract or ptosis or corneal opacity, and you're going to see that almost immediately. If there's something more subtle going on, I may not see it, but if there is a developmental abnormality in one eye, if there's a malformation of the structure of one eye, it's going to be incredibly evident by doing occlusion. Now, preferential looking is one of the primary forms of what we call resolution acuity. And you've seen preferential looking before. I'll show you a slide in a minute. And preferential looking is probably the best way of getting a quantitative measure. But preferential looking is not a clinical tool in most settings. It's a clinical tool in a specialty practice or in a hospital, but it is not a clinical tool in your office. Optokinetic nystagmus is often talked about, and in class, when you're a student, everybody talks about optokinetic nystagmus. Does anybody ever do optokinetic nystagmus as a clinical way of measuring visual acuity, quantitatively or qualitatively? And the answer is no. There are the rotating drums that exist, generally speaking, at a hospital, in a closet somewhere. I'll just point out, I spent the first 25 years of my career at the Boston Children's Hospital, which is the primary teaching hospital of the Harvard Medical School. So at the very beginning of my career, I started, it was very fortunate, started at Children's, and I was part of the Department of Ophthalmology at Children's, and the first optometrist actually at a pediatric hospital in the United States, and the first one at Children's. We use preferential looking as a critically important tool in the treatment of congenital cataracts and other conditions. But on a more generalized clinical basis, we don't do preferential looking, except under those conditions, and we virtually never did optokinetic nystagmus, and I don't know anybody who still does. Last thing I'll mention is visual evoked potential, VEP. And VEP is another technique that is always talked about as a way of measuring quantitatively visual acuity of very young children or special needs kids. And visual evoked potential is used in hospital settings. It's not used outside of that, to my knowledge, at least in the US. But an important differentiation between VEP and things like preferential looking or even fix and follow is VEP tells you whether the pathway, the visual pathway, from the photoreceptor in the eye to the back of the visual cortex is intact. It doesn't tell you about visual functioning at all. It tells you about the electrical connection between the front of the eye and the back of the brain. That's important in many conditions that are, again, outside the boundaries of typical clinical practice. So people talk about it, it's useful in certain settings, but in a clinical practice, you're not going to be doing that, or OKN, or for that matter, preferential looking. So fixes and follows, you can use a light, you can move it around. I actually like using toys. I much prefer that because you get better attention to a favorite toy of a child. And again, what you're looking for are differences in visual behavior. You're looking for the child batting your hand away or moving his head away from your cover. If you see that, you know there's something going on. By the way, you're also doing a cover test at the same time. You save time and you save effort doing that. This is preferential looking. This is the Stereoacuity card. This is the proper psychophysical way of doing preferential looking. I saw in some of the other presentations people using paddles, specifically Leah paddles. So Leah Hyvaronen worked out a system of using paddles. And in very sort of rough clinical practice, maybe that's okay to use. The people that I've worked with in the past and still currently who are involved in the development of the Stereoacuity cards as grad students under Davida Teller, doctor who's got her name attached to it, but in fact wasn't the one who did all the work. The people who did the work on the development of preferential looking were Velma Dobson and Louisa Mayer and Jeannie Hartman. And those people will say out loud that anything other than a large field stimulus, like you see on the screen, is not a proper psychophysical stimulus, that there are too many peripheral cues. So take that for what it is. And again, there's a child pointing. Again, there's Stereoacuity cards on the left, there's the Leah symbols, and in the middle is a whole chart. You present an entire chart like that to a 3-year-old child, and what happens? In almost every case, the child is simply going to shut down, almost like a computer crashing. Too much stimulus, child is overwhelmed by the stimulus, and you end up getting responses that are meaningless. So on the right, you see a reduced subset of the Leah symbols, and this is a paradigm we actually worked out many years ago. There were only 5 symbols with a crowding box around it. There's the matching symbols, the matching card rather, at the bottom of the light box. And often what we'll do is have a child hold the 4 symbols, present the individual ones to the child as we're presenting a stimulus. And the same with the HOTV. And in general, that's pretty much how it's done in the US, either this way or not on a light box, on a computer screen. And for the research purposes, that actually is what's used pretty universally in the US nowadays, is the HOTV on a computer screen with a particular automated paradigm going forward and a scoring system with a rapid staircase. I'm not going to go into too much more detail on that. Worth pointing out about occlusion. Now, if you want to get good occlusion, these are things you don't want to do. So putting a hand in front like top left, where the kid can look through the fingers and get essentially a pinhole effect to some degree, or a patch on the upper right that's peeled away and the kid looking off to the side, or sometimes in the US, people use paper cups. The right way to do it, if you want to get proper occlusion, is put a patch on the eye. If a kid rips the patch off one eye, doesn't rip the patch off the other eye, you know what's going on. Kid can't see. That's why the kid's ripping the patch off. So occlusion is critical. Still, when I'm doing a baby, I usually just break fusion using my thumb. I want to use something that is as minimally invasive as I can. If I want to get a more definitive covering, then I'll use a patch. But I know I'm going to get some behavioral issues with that. Let's go to ocular motilities next. I noticed on the presentation a couple of weeks ago, the presenter used the H pattern. So you go horizontal, you go vertical, and I would suggest that that's incomplete. I do that to start with, but then I always also do an X pattern. Why do I do an X pattern? Well, the ocular motilities that people obsess over with adults are related to eyes that go bad, eye muscles that go bad as a result of diabetes and thyroid and head trauma, car accidents, things like that. What muscles typically go bad in adults? The rectus muscles. What's the primary direction of gaze with the rectus muscles? Horizontal and vertical. With young kids, what are the muscles we worry the most about? The obliques, particularly the superior oblique. What is the primary field of action of the oblique muscles? Oblique, it's in the name. How do you best test that? Go in the field of action. So do your H first and do a broad X. By doing a broad X pattern all the way up and down, one side and the other, you get the best way of being able to pick out difficulties, problems with the oblique mode of action. Now, if there is a recent onset of an insult to the oblique muscles, you get a really robust response. Well, what happens after it's been present for a long period of time? Well, what ends up happening is you get secondary contractures and increases in function that compensate to some degree for what was at the beginning, when it first happened, very easy to detect, but later on becomes progressively more difficult to detect subtle abnormalities. So by doing an X pattern, going in the field of action of those muscles, it is much easier to see differences. So I always argue that you've got to do the X pattern in addition. Proper targets to use, again, I prefer to use a toy. Again, the favorite toy of the child. I'll use a light as well. And as I'm doing my motilities, I'm also doing a cover test. So I'm holding the toy, I'm doing my field of action, looking at motilities in all directions. I then do a cover test. And when I do a cover test, I always start out with alternate cover. Now, alternate cover going first is often different what is recommended in the textbooks, where they say cover, uncover. But I'm interested in finding subtle differences. I want to find subtle problems. And I'm interested in breaking down fusion as quickly as I can to bring out things that might be under some Fourier type control. So I want to break fusion. I put my occluder, and I almost always use a hand. I never use a black plastic occluder of any kind. Why do I use my hand? Because it's less intrusive to the child. The child is going to be less interested in trying to shove my hand in his mouth than he is a plastic occluder. How do I know that? 45 years of experience has taught me that. So I cover the right eye first. I leave the cover over that eye for a period of time. I then cover the left eye. I then speed up a little bit, and the first step is I'm also doing that visual acuity test that I mentioned. The second step is I've broken fusion. I now do a prolonged, as I think of it, cover test. After I've done alternate cover tests like that, not allowing fusion to be regained, my hand is broad enough that I'm not allowing even momentary regaining of fusion. Then after I've done that sufficiently, then I'll do cover uncover first on one eye and cover uncover on the other eye. And if I'm able to with an older child, or if I have somebody at the end of the room presenting some kind of appropriate stimulus, again, a toy or whatever, I'll do it at distance also. Now, one other thing I want to mention, and this is a little bit less so an issue for a young child than it is for an older child or an adult, and it's something that I almost never see in clinical practice. This is really different than the examination of a young child where it's really not an issue. But divergence excess intermittent exotropia. I'm going to talk about that for a second. So divergence excess exotropia, intermittent exotropia, typically occurs when you've got a larger deviation at distance and near. When do we do those tests? Well, we do it in our exam room. And our exam rooms are maybe, if we're lucky, 3 or 4 meters in length. Not many of us anymore have a 6 meter exam room distance. Nobody really has a 10 or 20 meter exam room distance. So if you do your cover test in an exam room with a 3 or 4 or 5 meter distance, is that really distance? Is that really infinity? No. If I have any hint by history or by my examination of any kind of an exodeviation at all, at any distance, distance or near, both or both, then I will take the child to a window. I'll have them look out the window at a really, truly distant object. I'll do the cover test again at that distance. And often, at an infinite distance, I will see a greater divergence, or maybe a divergence only at that distance and not in the exam room at all. So I just want to point that out. I think that's important. And it's really important with special needs kids, where you're much, much more likely to have a divergence excess exotropia in many of these conditions, particularly in cerebral palsy. Very common strabismus entity, and it often is not properly identified because you're not testing under the right conditions. Final thing about motilities, if it's hard to tell, using in a baby, I'm not going to pick up a special needs kid who weighs, an adult amount of weight, but I will pick up a baby and I will then twirl the baby around. I will, along with the baby, twirl things around. And I'm looking for OKN responses, optokinetic nystagmus responses. If I don't get it in one direction and I do in the other, I know there's a problem, and I can start going through a diagnostic evaluation to try to understand what it is. But you can literally pick up the baby and do movements. You can do it in a rotary fashion. You could do it up and down to look for vertical deviations. So that's a useful thing to do. And there's a light, and there's a baby smiling. And there's the examiner twirling the baby around, still smiling. Binocularity. All right, first of all, there is no binocularity at birth. So the whole binocular system is not developed. And I think that was talked about in the talk by Dr. Shah the other day. Many visual functions do not develop and are not present at birth. They may take 3 to 6 months to develop. Color vision, accommodation, convergence, these are all things that are not there at birth. There are many other things that are not there at birth. Photoreceptors are not fully developed at birth. One of the reasons why visual acuity is not fully developed at birth and takes a period of years actually to fully develop. So keep that part in mind. Vision develops. Deficits in vision at an early age cause deficits in visual development. Deficits in visual development lead to deficits in overall development. Again, this was talked about. One of the things that I do in babies after a few months of age is quite obviously, you can't do stereo testing in the usual way. So you can't put Polaroid or red-green glasses on a young child and say worth for a dot or a stereo fly or any of those kinds of tests. So how do you know? How do you get any sense at all if there is binocularity? Well, convergence. If you don't have convergence, you don't have binocularity. It's as simple as that. So if you move an object closer to the child and that child converges, then you have some sense that there is at least a rudimentary level of binocularity present. How important is that? Well, that's really important. How hard is it to do while you're doing EOMs? This is part of the system of maximizing speed, maximizing efficiency. You do this binocular testing looking for convergence while you're doing these other tests. And it indicates the presence of cortical fusion. So again, stereoacuity, convergence, 4-diopter base-out test. I might have mentioned that, I think, in one of my talks about refraction. And for me, the 4 base-out test is a critically important test. Anytime there is a question about binocularity, and especially anytime there is a question about an isometropia. So I do my refraction, and I see a 4-diopter hyperopic difference between two eyes. I pretty much know there's going to be a positive 4 base-out test. I think I described this before. I'll just go over it real quickly now. To do the test, you put a 4-diopter base-out prism in front of one eye. As you put the prism in front of that eye, you look at the fellow eye. You expect to find that eye make a transient movement outward and then a transient movement inward. So Herring's law says you've now moved the image on the eye behind the prism to a nasal point. Herring's law says nasal point movement on that one eye is going to cause a temporal movement on the fellow eye, and then there'll be a refixation movement inward on the fellow eye. So you now put the prism in front of the other eye, and you see no movement on the fellow eye. What's happened? The prism moved the image on the second eye to a position off of the fovea, but still within what we call a suppression scotoma. There is an actual functional suppression area surrounding the fovea that leads to suppression, and that suppression allows that child to not develop diplopia. If there was diplopia, that's a very disrupting condition. It won't last for long, and the movement of that eye to get that eye moving off the image off the fovea to an extrafoveal point allows suppression to occur and allows a rudimentary form of binocularity to, in many cases, continue to exist. So if you could measure stereo in an older child with a positive 4 base-out of microtropia, you may find a limited form of binocularity, maybe 100 seconds, 200 seconds, 400 seconds of arc, something like that. You won't get 20 or 40 or 60 seconds of arc, however, because it's now an extrafoveal point and the fine-tuning is gone. So I think 4 base-out is really important, and you can also use that, again, as a way of getting a rudimentary form of stereopsis testing. Finally, Brückner test. I'm going to talk more about Brückner in a minute. So again, there's the pen light. You move the pen light in, NPC. Again, I'll either use a pen light or a toy, or often I'll do both. Typical forms of stereopsis testing. The one on the right is the smile face. Essentially, it's a RAND.E with a smile on it. That happens to be set up in a paradigm that is similar to preferential looking. So you can establish a preferential looking stereo test using a stereo smile, which one of my co-investigators in the VIP study, Elise Senior, developed at the Philadelphia College of Optometry many years ago. We're going to talk about Brückner. Brückner, I think, is one of the most important tests that is taught, but then, in my experience around the world, almost never done. Why? I don't know. I actually do Brückner tests before I do anything else. One, I bring the patient in the room and I'm doing my observation and I'm taking my history. I will whip out my direct ophthalmoscope. I will darken the room a little bit, not a whole lot. I'll put about a +1 in the ophthalmoscope, the direct ophthalmoscope. I'll then look at the child through that. I'm lighting up both eyes. If I'm able to get the child to look at a far object by having a toy at the end of the room or a colleague at the end of the room making noise, I'll do that. The idea is if a child looks at a far distant object, what happens to the pupil compared to when the child is looking at a near object? Well, quite obviously, you are affecting pupil size. Child looks at near, convergence, meiosis, and accommodation are occurring. The meiosis is the important part. When you make the pupil smaller, you decrease the amount of light reflecting off of the retinas. By decreasing the amount of light reflecting off the retinas, you are effectively decreasing the contrast and the total amount of illumination. You're decreasing what you are able to view. When you have big pupils, you have much more light reflecting off the retinas. And what I tell my students is, anybody remember what the formula for area of a circle is? Yeah, pi r square. So you increase pupil size, you increase the area dramatically. So the amount of light reflecting off a big pupil is dramatically larger than the amount of light reflecting off a small pupil, off the retina. Not only that, but you also have a bigger image to look at. So the various components of that light reflex are enlarged. You're getting magnification. What am I looking at when I'm doing Brückner test? Well, I'm looking at the color of the reflexes, I'm looking at the brightness of the reflexes, and I'm looking at the position of the crescents or shadows within the pupil. And in doing that, I am able to evaluate a number of different processes going on. First of all, if there is a medial opacity, a cataract, or a corneal opacity of some kind, you're going to get a dark area in one eye, and maybe you'll get a wipeout of the red reflex. If one eye is much brighter than the other eye, then that is potentially an indication of strabismus, because the light on the strabismic eye is not reflecting off the macula. It's reflecting off an area of the retina that is not the macula. The macula is more pigmented, therefore it's absorbing light. Therefore, the reflex coming off that eye is going to be brighter. So that is a way of determining if there's strabismus. Strabismic amblyopia, the first case of cataract, deprivation amblyopia. The position of the crescents, if you have a hyperopic eye, the area on the bottom inferiorly is going to be darker than the area at the top. If you have myopia, the area at the top of the light reflex off the pupil, off the retina rather, is going to be darker. So dark reflex inferiorly is hyperopia. Dark reflex superiorly is myopia. If it's shifted a little bit away from 6 o'clock or 12 o'clock, then that means that there is astigmatism built into the spherical component. If you see a big difference in the appearance of those dark crescents, that is an indication of unequal refractive error. So I do this before I've done anything else. How long does it take? Seconds. Not only am I doing that in that way, I'm also doing pupils. I shine the light off of both eyes as I'm looking through the ophthalmoscope. I shine it on one eye. What do I see? I have a light source and a magnification source with the ophthalmoscope. I'm able to really easily see the pupil response. I challenge many of you to actually see the pupil response on a child with really dark eyes. It's hard. You've got a dark pupil on a dark iris. It's hard to actually see it. This way is easy to see, and you can do a swinging flashlight test to look for an APD, afferent pupillary defect. Provides information about all three types of amblyopia: deprivation, strabismic, and refractive. And that's the technique. And you could see on the left side, you can see much brighter reflex on the left eye than the right eye of that young woman. Top right, you can see easily a cataract. And on the bottom right, you can see a brighter reflex as well on the bottom right. Again, differences. Top here, you can see the really dark reflex at the top one, inferiorly rather, and on the left eye, it's all bright, definitely unequal refractive error. And some examples here. So the bottom line is that with Brückner, you can get a lot of information. Refraction, I talked last time about non-cycloplegic retinoscopy and cycloplegic retinoscopy, how they are different tests telling you different information. I've seen a couple of references in prior talks to the Mohindra technique of near retinoscopy. I mentioned in my first talk that Indra Mohindra was actually my teacher when I was a student. She did the research on the Mohindra infant retinoscopy technique while I was a student. And it turned out that, in fact, studies that have been done subsequently have shown that it's not a very accurate test. It gives you some information, but it's not all it's cracked up to be. And in the US, there have been, as I said, a couple of really solid studies that have shown that it's not a very good test. So I do both dry refraction, then I do wet refraction, and then I base what I'm going to do on that. Autorefraction in young kids, in my view, is a screening technique. It's useful as a screening technique. I don't see any use for it as a diagnostic technique. You know, lots of people use it. They recommend it. I don't think so. Subjective refraction in a young child is not going to happen. In a special needs kid, it's not going to happen. So obviously, you can do subjective refraction when you can, but it's certainly not something that's going to be, you're going to be dependent on. I mentioned a couple of times my overriding principle of correcting refractive error is put a focused image 360 both eyes simultaneously. Nice way of saying keep the difference between eyes in your correction, fully correct the astigmatism. Ocular health exam, observation again. You've done pupils, you've done Brückner, you look the anterior segment and the posterior segment. I look with lights and then I do ophthalmoscopy to the degree that I can. And then I always do binocular indirect ophthalmoscopy. I don't believe that you can do a thorough ocular health examination without doing binocular indirect ophthalmoscopy. Again, I fully recognize that many of you are not in a position where you can use drops. If you can't, well, do the best you can, but you are in effect only kidding yourself. You're only seeing a minute percentage of the retina through a undilated pupil. In a baby, you're not getting much of anything. You really can't do a direct ophthalmoscopy of many babies. It's just not going to happen. Use a slit lamp if you can. There are handheld slit lamps. You can use an ophthalmoscope and a handheld lens. Variety of techniques for looking at the anterior segment. I use a direct ophthalmoscope as much as I can. High power, +6, +8, +10. Bright source, get magnification. Very useful and underappreciated. Special testing, again, I mentioned all of this. Visual fields when indicated. Again, this is not a technique you're going to use in a clinical setting. I mentioned OCT here. There are great uses for OCT, but using it in a young child or a special needs kid is challenging. It can be done. Probably it's a hospital-based procedure. My infant exam procedure is essentially 10 minutes before drops, and then 5 or 10 minutes after drops. My contact time with a child, a young child, or a special needs kid is maybe 15 minutes. That's it. Why? Because you're not going to get much more than that. I got to try to get all the information I can possibly get as quickly as I possibly can. And that's going to have to be in a very short period of time. So I bring the patient, mom, in the exam room. I'm doing my observation. I am taking a history simultaneously. I pick up my ophthalmoscope. I do Brückner. I put the ophthalmoscope down after I've done Brückner and I've done pupils. I've also done a cursory examination of the anterior segment by using the ophthalmoscope. I then do my visual acuity by doing my cover test in the way that I described. I then take that same toy, I do convergence testing, I do EOMs, cover test. I do all of that in a period of like a minute or two. I then do dry retinoscopy. I'm still taking a history as I'm going along. My retinoscopy, as I talked about the last couple of times I spoke, is using handheld lenses in front of both eyes simultaneously. I put extra plus in front. I'm sweeping rapidly across both eyes. I'm doing what I call a simultaneous retinoscopy. This is to try to reduce accommodation if possible, but I'm also looking for an isometropia. I then put drops in. And then after I put the drops in, bring the child back. I do my wet retinoscopy in the same manner I described before. I then do BIO, and I'm done. Real briefly, ocular pharmaceutical agents, anesthetics. I don't use anesthetics. Some people put an anesthetic drop in first before putting a cycloplegic agent in. My view is the drop that I get in the eye, I want to be the drop that's going to work. I go straight to cyclopentolate. I basically use cyclopentolate, which is both a mydriatic and a cycloplegic. It's not the best mydriatic. If I want to get a better dilation, I'll put tropicamide in as well. I will not use phenylephrine. And the reason I will not ever use phenylephrine on a young child or a special needs kid is I had a couple of disasters in my experience when I was at the hospital. Thankfully, I was in the NICU, the neonatal intensive care unit, doing retinopathy of prematurity rounds. We would put a combination drop in, and in 3 occasions in my own personal experience, the phenylephrine actually caused cardiovascular episodes in tiny neonates. I will not ever do it again. The protocol in the US is to use an absolutely minimal dosage of that. But if I'm not in a neonatal intensive care unit where all the heroic efforts to keep a kid alive can be done, if it's in my office, I'm not going near neosynephrine, phenylephrine. So I put cyclopentolate in. In a baby, I'll use 0.5%, 1 drop. In an older kid, I'll use 2 drops of 1%. Typically what I do is I lie the kid down on the mom's arm. I grab the eyes firmly. I open the lids. I squirt in one eye, then I squirt in the other eye. I do it really fast to try to get the drops in before the kid can react. And then I wipe the excess away, and the kid will cry. And the kid comes back in. Do I worry about whether the kid's going to now hate me because I put drops in? And the answer is that virtually never happens. That's a myth. So that's how I use drops. Real quickly, some clinical modifications for special needs populations. The necessity of getting a thorough history is really imperative. So in an older special needs kid, you need to know all the other stuff going on with this child. You need to know all the medical history, all the other educational issues going on, what the concerns of the parent and the patient might be. You need to get a much more thorough history, and I prefer to be able to evaluate all that ahead of time and be able to ask questions ahead of time. Because once they get into my exam setting, once again, I've only got a limited amount of time that I can get. I'll do all the essential tests as quickly as possible, and then do additional things as time allows. And the time allows is not my time, it's the child's time. The child will allow me to do more things, then I'll do more things. But I may only be able to do a very small number of things. Keep in mind that special needs does not necessarily mean mental disabilities. There may only be physical disabilities. Very often a child with cerebral palsy, which cerebral palsy commonly is a common problem, and I'd say 85% of individuals with CP have got important vision problems. 85% of individuals with Down syndrome have significant vision problems. These kids need to be seen. The CP kids may not have mental retardation at all. Downs kids probably will, but I've had some Downs kids that have had high IQs, probably higher than mine. The various kinds of handicaps that kids have may really present incredible complications to the examination process. And very often, these are kids that require more specialized care, not in a typical clinical setting. One of the conditions that comes up all the time nowadays is autism. Now, people talk about autism, they talk about the causes, they talk about the increase in the number of cases, lots of issues like that. I'm not as convinced as some people that there's been an explosion of epidemiology over the last 30 or 40 years. I'm old enough to remember that when I was in elementary school, there were classrooms of kids who had various labels attached to them, most of them not nice labels, that were in the same building that I was in getting a typical education, who clearly in retrospect were autistic. They had all the manifestations of that. So I think that in large part, we're doing a far better job of diagnosing, and we may in fact be overdiagnosing to some degree. The numbers, percentages in the US are now thought to be anywhere from 1 in 50 to 1 in 100 births. I don't know if those numbers are correct or not. What I do know is that in my city, even in Boston, with amazing access to very advanced pediatric healthcare resources, some of the very best in the world in Boston, including my old hospital, Boston Children's, the number of eye doctors who are willing to see kids with autism is incredibly small. So getting access to care for those kids is a real serious issue. And some individuals, like myself, enjoy taking care of those populations and end up seeing a disproportionate share of that population. Other practitioners, even pediatric specialists, want nothing to do with it. So my examination for kids with autism, especially older kids, is I do what I call a remote examination. And what that means is I keep as far away as I possibly can from the exam itself. In other words, I try to do things at a distance. Why? Because you never know when the child is going to get stimulated and explode and jump on you and hit you and beat you. And believe me, it's happened to me many, many times. So I like having a desk in front of me and the patient, something to protect me a little bit. And I do my Brückner and I do my retinoscopy at a distance, and I do other kinds of testing at a distance, and I try to do the best I can. And if I find that I'm able to get what I need, then I'll come closer. Putting drops in is a lot more problematic. That's a great way of setting a kid off. So you may not really be able to do that, and it may not be wise to do that. So you have to kind of do what you can. Question is, are there more problems, eye problems in those kids than in other populations? And the answer is, we really don't know. The studies that have been done are, in my view, all incomplete. In my own experience, am not so sure that there are many more problems in that population than in typical populations. I will say one thing with some degree of certainty: there is less myopia in kids with autism. Why? Probably because they're not doing the intensive reading that typical kids are now doing nowadays. So I find much less myopia. I find just as much astigmatism. and I find hyperopia at younger kid levels. So what do you do with special needs kids? You got to prioritize the exam. And in many cases, you need to have these kids come back. It's complicated, but it's also extraordinarily rewarding. Whether or not you can do this in a typical exam setting is problematic. Speed, speed, speed. And at that point, I'm going to stop. So hopefully there's some questions, and I appreciate your interest and hope that this practical approach to the examination process can be of some use to you. As I've said now a number of times, I would go back for all the audience, look at some of the other talks that have been given. They provide details that I think are incredibly useful. And in many cases, those lectures were, I think, geared more towards people who have the luxury of an advanced setting like a children's hospital or a specialty type of practice. And I hope some of what I said today will be of value to you in more typical clinical settings. The bottom line is you got to be fast, you've got to be efficient, you've got to get your information as quickly as you possibly can. And if you find that you're in over your head, if there are issues that go beyond your ability, then absolutely, positively, feel free to refer these kids to individuals that are in a better position to be able to provide more extensive levels of care. So I will stop there. Thank you, and I would be happy to take some questions.
Thank you very much, Prof. It was wonderful, and we definitely have, much more idea about doing the eye examination. And there's one question here, Prof. I'll just read it out for you. It's about autistic patient. One of the attendees have an autistic patient, and they were required to do a visual field assessment. And it was rather challenging, but at the end, they managed to do a GERM. At the end, they did really manage to do a GERM. Do you have any suggestions or tips on how to establish the fields as accurate as possible?
Well, again, it's very challenging, as was pointed out. There actually is a technique that has been developed for special needs kids that people on my faculty at the New England College of Optometry have designed, that something called a Kong wand. And what that is for some of you remember the old tangent screens. We used to use a black wand, about black stick covered with felt that would have a target at the end of it that you would use on a tangent screen. They actually devised a technique of doing visual fields using stimuluses, white stimuluses, and in fact other kinds of stimuluses attached to this wand that would be presented to the child with the examiner standing behind the child and presenting the stimulus towards the front of the child in all the various positions of gaze. If you do a Google search, there's been a couple of talks presented at the Academy of Optometry and ARVO meeting, and I think a couple of papers have been published on that. If you do a Google search for Kong wand, K-O-N-G, one word, wand, W-A-N-D, I think you can find the particulars for that. It is, I think, a brilliant technique, and we use that in our clinical settings at NECO, and it has worked out incredibly well for this very high-risk populations. One of our clinical settings is at the very famous Perkins School for the Blind in Boston, and that technique was actually developed at Perkins by our faculty. So the Kong wand, and again, that would be a Google search for you to do. You'll be able to find it. Thank you for that.
Okay, Prof. The other question is, any test that objectively check the speed eye movement accurately, or any mobile software you would recommend?
That developed the what eye movement?
The check the speed eye movement accurately.
Speed eye movement activity. I'm not sure. I would say that software for young kids is not real. You can't, it's not enough of a stimulus for a child to be interested looking at that. Now, granted, every baby looks at cell phones now at a few months of age. They probably have more attention to that than almost anything else. So maybe in the future, people are going to develop various kinds of testing paradigms that are going to use things like cell phones or iPads or computer screens. But I wouldn't put a lot of hope in that. I think that's going to be very, very dependent on individual children. I really don't know how to answer that question.
Okay, Prof. And will APGAR score actually help in evaluating vision? Is there any relation
I'm
about
sorry,
the
say
APGAR score?
that again?
Does the APGAR score help in evaluating vision?
No, it really doesn't. One of the things that my group has been interested in, and we're doing research on, we're looking at screening techniques for children under the age of 3 years. The talk the other day talked about early intervention programs, which is incredibly important. And again, I really congratulate Dr. Shah on bringing that into the discussion for this group. We have also been looking very deeply at how we can provide better care as a screening technique first to identify kids in early intervention programs in need of comprehensive eye evaluations. I would actually say that any child in a formalized early intervention program should have an eye examination, but the resources to do that are not available anywhere in the US or I suspect beyond that for every child. So it means we've got to identify those kids most in need. And, you know, pediatricians and parents can do some of that, but it leaves a lot of gaps. So one of the things that Dr. Hyvarinen, Leah Hyvarinen, was involved in Scandinavia 30 years ago was the development of techniques to identify young children with vision problems in need of comprehensive eye exams at young ages. And now, you know, we're playing around with automated refractive photo screeners, and they look to be quite useful. And we've looked at that as well. As I said earlier, I've done research for Welsh Allen using the spot, and we've looked at that for children between birth and 3 years of age, and there is clearly value in that. But if you're only using a refractive technique to screen for very young children, you're only looking for refraction. Refraction is not everything. Refraction is not visual function, for example. So what is visual function? And again, Dr. Shah talked about this. Things like, an example, if a pediatrician asks a mother, when you smile at your baby, does your baby smile back at you? Is that an important question for a pediatrician to be asking? Well, of course it is. Why? Because it tells you a lot about the child's socialization, relationship to the mother, really critically important things like that. But what if the kid can't see? What if the kid's got some abnormality of the visual system, a structural abnormality anywhere from the eye to the brain, or remarkably high refractive error, or something else impairing vision? Is there something we can do that would be simpler than doing testing? And the answer is, in Scandinavia, in Finland specifically, they developed techniques of doing visual developmental screening 35 years ago, asking questions like that. So we began looking into that. And to be honest, nobody in the United States had really thought about anything like that as a screening tool. We put together a series of visual developmental questions that are valid at different ages between birth and 3 years of age, different questions in some cases for different ages, along with what we think of as risk assessment questions. You remember back to the first video I showed today that Leah showed about the child with quote unquote infantile autism, and putting the glasses on changed the whole child's behavior?
Yeah.
Think about that. Think about how if anybody had asked the question, are there any other children in the family with big, thick, ugly glasses or crossed eyes, how you would have then identified that baby as being in a high-risk group. We know that is absolutely the case. One sibling with bad eyes equals a risk for the other siblings with bad eyes. So we put together questionnaires, 5 visual developmental questions and 5 risk development questions. And we're now about to start a second phase of a research study looking at the efficacy of that in comparison to refractive screening alone. We, in the first phase, compared the spot and those visual developmental questions in an early intervention population of 250 young children up to 3 years of age. Did a gold standard comprehensive cycloplegic eye examination and found that the visual developmental questions were as good or better than the refractive screening with the spot at identifying kids with important vision problems. So bottom line, in the future, we are going to be developing, and it's not just our group, this is around the world, we're going to be developing batteries of questions that are going to put us in the position of identifying kids at risk of vision problems in these high-risk categories. So I hope that answers the question.
Yeah, definitely. And are there any tips or your assessment strategies when it comes to non-attentive kids or people or kids having cortical or cerebral insult where the vision might be poor? So are there any tips you would like to share with us?
Well, okay, so you're talking about really 2 different categories that often merge together. There's visual inattentiveness in young children, and there's cortical visual impairment, which is a confirmed diagnosis of a child with visual inattentiveness. These are all categories of kids with severe vision, potentially severe vision problems. And I guess what I would say in that context is these are incredibly complex kids with incredibly complex vision problems. The ability of being able to do the right thing for children in anything other than highly specialized places of care, sort of like a children's hospital or highly specialized pediatric eye care practices, is really beyond the ability of the vast majority of clinicians. One of my colleagues at NECO at Perkins, head of the program at Perkins, Professor Barry Cran, is actually also a close colleague of Leah Hyvarin, and he is a world expert on this issue of visual inattentiveness and cortical visual impairment. He put on a symposium at the American Academy of Optometry meeting a couple of years ago and brought in world experts on that issue from everywhere around the world to the Academy meeting. And there is a lot written on it, but I will tell you that there are very few practitioners around the world that are highly skilled and willing to provide care to those populations, because it is really hard. It is really complicated, and these kids need a whole lot of care. So bottom line, I think that specialty care situations are appropriate places for those kids. You have children in your practice who have manifestations of that. These kids should be referred to higher levels of care if available. If not, then I would say that these kids have got a whole lot of problems that go way beyond vision, that are all kinds of developmental and all kinds of health related.
Okay. And coming back to autism again, so will you prescribe prescription or glasses for autism on the first go, or would you try to develop other functions like saccades and pursuit and then go on prescribing glasses?
Okay, well, interesting question, and specifically the part about saccades and pursuits. And it may be that the person asking the question knows more about this than I've mentioned or has been mentioned before. So one of the abnormalities that is pretty well recognized with kids with autism is a problem specifically with pursuits and saccades. So voluntary saccadic movements, voluntary pursuit movements, I should say, are either impaired or absent in many, perhaps a majority of individuals with autism. It may or may not ultimately turn out to be a diagnostic sign. That is not clear at this point, but it has absolutely been associated. So what I mean by that is that if you do fix and follow, if you take a toy or an object and move it in front of a child with autism, many, if not most, will be unable to have smooth pursuit movements. They frequently will have a series of jerky saccadic movements with overshoots and undershoots that are used in lieu of, instead of these smooth pursuit movements. And I actually think that what we're going to find out in the future is that whatever the neurology of autism is going to be related to the neurology of eye movements. And I think we're going to learn a lot about that relationship down the line. So getting to the other part of the broader part of that question, do I prescribe? The answer is I will if indicated. Now, what do I mean by that? I got to be persuaded that glasses are really going to make a significant difference for this kid. Am I going to provide a pair of plus 150s for this kid? The answer is no, I'm not. Why? Because with all the other parental and educational complications that this child has for everyone around them, parents, schools, everyone else, in terms of management and education, I don't want to put another problem heaped upon everything else on those individuals. If I think it's going to make a real difference, if the kid, for example, is a -7 myope or a 4 diopter astigmat, then I'll do it for sure. So if I think that it could lead to improved behavior in other ways, I will absolutely go about doing that. And I'll probably do it on that first visit to see what happens. Even though I may be off in my refraction and my examination, I'm probably going to be in the ballpark. And if I'm off by some, it may not make much of a difference. If I'm off by a lot, the kid's not going to wear it anyhow. So if I prescribe and the kid wears it and benefits by it, then that's a great thing. If not, then we'll reassess. Good question.
Okay. Yeah, and I think it's a continuation of the same question. What about the treatment of exotropia in cerebral palsy? As you mentioned, it is more common. So we are interested in the lens prescription ideas for the same. What would you do in that cases?
Okay, well, another great question. Lots of great questions coming from out there. As the questioner pointed out, exotropia is extremely common, more common than esotropia. What you actually find in the natural history of cerebral palsy is that often often you'll find that these children in the first year have straight eyes. The parents do not notice a deviation. And then they start noticing at some point, either early or a little bit later, development of intermittent esotropia. Sometimes the esotropia will become constant, but often it's intermittent. Depends upon the child's overall level of stimulation, awareness, awakeness, all the other neurological complications and factors going on. And then what you very interestingly find is that the esotropia decreases, turning into an exotropia. So there lies one of the first problems, in that some strabismus surgeons see the esotropia early on and say, I can help this kid. Let me go ahead and do a surgical procedure. And what happens when you do that is you end up messing things up much, much more so. So strabismus surgeons who are knowledgeable will not, for the most part, except in rare circumstances, do any kind of strabismus surgery on these kids early on. And many, frankly, won't even do it until much later, if at all. In other words, they leave these kids alone. Because if you do early surgery, you end up creating a problem in the opposite direction. In other words, a consecutive exotropia. Now, even if you leave these kids alone, do nothing with the esotropia, they'll often develop the exotropia later, which usually is intermittent and usually is a divergence excess. So if you go ahead and do your testing in free space, in other words, as I suggested earlier, do it near in the exam room, do it at somewhat distance in the 3-meter exam room, and then take the kid either outside or to a window and do it again. You will often find astonishing differences in the amount of deviation at different distances, which obviously is the definition of divergence excess. So what do I do? Well, your options are really the same as what they are in typical populations of divergence excess. In other words, not related to cerebral palsy. And that is, you can do vision therapy, which may or may not be more or less useful in this population than in typical kids. Probably less useful because there is a more basic underlying problem, if you will, weak muscles in general underlying everything, therefore weak ability to overcompensate by developing enhanced strengthening of those muscles, or potentially initiating accommodation. In other words, giving over-minusing, as now is one of the dominant treatments for intermittent divergence exotropia in typical populations. So what would I do? Probably, if it was reasonable and relevant and fit into the overall refractive status of the child, I would go ahead and try the over-minusing. Now, obviously, that doesn't solve the problem at age 20 or 30, but it may make some improvement in the earlier years. So bottom line, don't do surgery. Try the usual treatments for it, either VT or over-minusing.
Okay, we have the last two questions, Prof. If you don't mind, we'll just take them. This is from Shama Shah, the one you referred to in the talk. She's present today.
Thank you for listening.
Yeah, and she's very happy that you also, commented on her talk as well. So, yeah, could you please share on visual field testing for pediatric population? Do you think that confrontation test is advisable, or do you have any other testing strategies for measuring or testing for visual field?
For visual acuity?
Visual field.
Visual field.
Yeah.
Well, again, I'll go back to the Kong wand. I think that is really a brilliant implementation of it. Other people involved in that, Louisa Mayer, who is one of the developers of preferential looking, has also developed a whole variety of enhancements to typical visual field testing in those children. And I'll refer you to Louisa Mayer, M-A-Y-E-R, Louisa, first name. I'll reflect you back to her voluminous, extensive series of papers that she's written on visual field testing. So if you like, check out the following authors: Barry Cran, Louisa Mayer, and Jackie Kong, K-O-N-G, the inventor of the Kong wand. They all work together on those projects in visual field testing. And I think that they've done an amazing job. There's also a group out of Scotland, and I am blanking, unfortunately, on his name, Alistair something, who is one of the world experts on visual inattentiveness, who's developed a number of techniques about visual field testing in these special populations. They've also done a lot of work. I know there's a textbook that I think Leah Hyvarinen has also published that also goes into a lot of detail about visual field testing. Leah has done a whole lot of work, and I know she's traveled around the world and spent a lot of time in India, and maybe some of you in India have had the opportunity of working with her in some of her visits in the past. She also has done extensive work. They are, frankly, far more expert in visual field testing in that population than I am. Over all my years, I have, to be honest, always referred my patients to that group to do the more extensive testing. I am very, very comfortable in staying within my narrower areas of expertise and referring to others with vastly more extensive experience than I have. And I urge all of you to think in the same context. In my view, that is the hallmark of a great clinician, is the willingness, maybe even the eagerness of referring to your colleagues who know more and can do more than you can do. So thank you for that question. And again, just say it the last time, great talk you gave.
Yeah. The last question, Prof, is from the same person, mentioning about these batteries, whatever the visual development screening was generated is for the normal children up to 3 years, or is it for the visually impaired kids?
Okay, well, good question. Actually, that was for all children to identify those with significant visual impairment. So we are looking for an effective screening process for younger children. My research over many of my years has been involved in developing and enhancing vision screening for preschool age children 3 to 5 years of age. I'm an expert in that. I've done a lot of work in that. As we were doing work in that area, we recognized that there was a population of kids younger that we really did not have a clue about. Now, most of you will not be aware of this, but there is an organization in the United States that is part of the United States government's Department of Health and Human Services that has existed since the 1940s, called the United States Preventative Service Task Force. And that organization has the responsibility of evaluating every single health-related screening technique used in the United States and approved by the US government. So every single screening technique that you can imagine has been evaluated by this group. Things like for breast cancer, for prostate cancer, for cystic fibrosis, for HIV, for COVID-19, for vision screening. They are involved in doing an intense literature review, evaluating the efficacy of the studies done to determine if there are screening techniques that work to detect these conditions in a pre-disease state. They issue a report about every 5 years on vision screening of kids under the age of 5 years. They have been reporting on the 3 to 5 year olds. And when we, the VIP group, started out back in the 1990s, mid 1990s, their evaluation on 3 to 5 year old screening was that there were no techniques. We don't know if it's of value. We don't know any techniques that work. That was one of the reasons my group got funded by National Institutes of Health, because there was a need to understand that. Well, we've gone a long way towards solving that issue. They now get, the Preventative Service Task Force gives us a high rating that it's an effective technique for 3 to 5 year olds. They continue, even 2 years ago in their latest report, to give screening under the age of 3, from birth to 3, an incomplete. They actually give it an incomplete, like in universities, saying that there are no techniques for birth to 3, and we don't know if earlier detection actually leads to improved outcome. So as part of that, my group and others around the country have really begun trying to think about how we can screen that population, not only of high-risk kids, but of normal risk kids. And we have been working on this issue, and other groups have, and a lot of attention has been paid to these photo screening techniques. Nice and simple, not inexpensive, they're $7,000 US, but do they work? And the indications are they work okay. And the reason they only work okay is because obviously you're only screening for refractive error, which is a structural problem with the eye. It does not tell you about a functional problem of vision. Two very different things that in some cases are related, but in many cases not related. And you can think of visual inattentiveness as a perfect indication. You can have a child with cortical visual impairment with a refractive error of Plano. Does that mean the eyes are okay? No. Visual function is grotesquely impaired. So we need to know something about function. And that's why we are developing these questionnaires. And as I said, we're now about to begin phase 2 testing on a large population of normal kids in pediatric primary care well child visits, as well as another population in early intervention programs. Now, early intervention programs in the US are funded by the federal government for every state. And that means that any child with any kind of developmental abnormality detected under the age of 3 is put into a program of diagnostic testing in a myriad of ways, all different kinds of ways, and then also treatment, whether it's motor or cognitive or developmental. However, there are extensive programs in every state. The program in my state, in Massachusetts, is frankly more extensive and gets significant additional funding from the state in addition to the federal government. So that by the time children reach 3 years of age, actually 20% of Massachusetts children, 75,000 born each year in Massachusetts, 20% of those 75,000 kids at one point or another have received early intervention services in Massachusetts. Throughout the United States, the average is closer to 10%. So that means that not only are the kids who are severely impaired in our program in Massachusetts, but also kids who are mildly impaired are also in that program, have received services. So our early intervention program is a wonderful place for us to do additional testing. And then we look at normal pediatric well child care, kids coming in for immunizations at appropriate times, is for the normal population. So we're about to embark on an extensive study of that. And on our first pilot study with questions that we found can be improved and probably improve the sensitivity and specificity, in other words, identifying kids with issues, will no doubt get better on a second phase. So we believe we can probably do quite a bit better than refractive screening alone at very low cost, done by people other than eye doctor types. These could be done by almost anybody in an early intervention program, in an early education program, sort of a daycare setting, or in a pediatrician office. So it's not restricted to just eye doctors doing the screening, which we think is really, really important. We want all children to undergo that. Now, when we develop this, it'll be just as useful in Boston as it will be in Malaysia or India or any other place around the world, because child development issues are no different in any country in this world at all. So what affects children in one place will affect children in a different place. Getting the nuance of the questions right for the language will be the hardest part once we get the right kinds of questions. There may need to be modifications based on that. But we think the future of early screening for vision problems is going to be by questionnaires and a combination of visual developmental and risk assessment. And we think that we will then be able to identify the 10 or 15 or 20%, whatever the number is, of 1- and 2-year-old children who need a full eye evaluation to ensure that improper visual development is not going to impair their overall development and their overall educational attainment, which to us is the most critical issue of all. We want to make sure that every single child in the US, every single child around the world is properly prepared to get the full benefit of their education by ensuring that vision is not an impediment. I will stop there.
Yeah, thank you very much, Prof. I think we have taken almost all the questions, and once again, thank you very much for giving us the time and sharing with us the ideas. And I think all of us definitely find it useful, and we would like to hear from you again in the nearby future as well. I'll just share my screen now for them, for the attendees to know
Thank you again.
about the next week. Yeah. You're most welcome, Prof. So yeah, next week on a Saturday next week we have the very hot topic these days going about what do we do in terms of COVID-19. So we have Optom Shiny Sebastian, and she is going to talk to us about the visual hygiene and ergonomics in times of COVID-19. So I think this is very important because now I think things are getting better and people are starting to join work, go to clinics, and we would definitely need some tips on how we are going to maintain that social distancing and everything, and in terms of visual hygiene as well. So please tune in next week on Saturday. It's 2:30 afternoon in India and 5 p.m. in Malaysia. Until then, stay home, stay safe, and see you all again next week. Bye.